right, 42-year-old man, emergency department, diffuse skin rash. He took arvastatin for hyperlipidemia, and there's no Nikolsky sign. Which of the following is the underlying mechanism for his condition? So take a second to kind of read this. So we have this drug eruption here because we have history for epilepsy. We've got numerous erythematic macules and papules covering the trunk and these extremities, sparing palms and soles. So we have a morbilliform, so a measles-like drug eruption, a type 4 hypersensitivity reaction. This rash is a diffuse erythematic macules and papules that are symmetrically involving the trunk and the extremities, 5 to 21 days after a new medication. And the most common culprits of this would be lamotrigine, phenytoin, antibodies, the sulfas, beta-lactams, and antiretrovirals. Low-grade fevers can also accompany this, but systemic symptoms are just going to be mild. Mucosal involvement is absent. That's how you distinguish it from Stevens-Johnson syndrome. So what's the mechanism at play? Well, multiform drug interactions are type 4 hypersensitivity reactions mediated by the T cells. And so the antigen-presenting cells are going to process the drug and its metabolite via the MHC class 2 molecules. And that will be presented to the naive CD4 positive cells, and then they'll differentiate into Th1 cells. And then the Th1 will release the interferon gamma, and those will stimulate macrophages and cytotoxic T cells, and leading to the keratinocyte apoptosis and the formation of our beautiful little rash. And it takes several days to develop. And so that's why our correct answer is going to be delayed hypersensitivity reaction. So it's a type 4. And antibody-mediated complement, that'd be a type 2. So that's like pemphigus vulgaris and autoimmune hemolytic anemia. Those would be IgGs and IgMs binding to target cells that lead to complement activation and cytotoxicity. And pemphigus vulgaris would have painful blisters and mucosal involvement. C, direct keratinocyte toxicity by a viral infection like measles and parvovirus. So those can cause a morbilliform rash, but they don't have the prodromal symptoms in this patient, like the cough, conjunctivitis. So that's going to make a viral etiology less likely. D is going to be our immune complex deposition. That's a type 3 hypersensitivity. Serum sickness, immune complex deposition after drug exposure. So serum sickness would have fever, joint pain, urticaria, rash, not the morbilliform xanthum that we see in this question. So last one, mast cell degranulation with histamines. That would be type 1, seen in the, you'd see like with the hives and anaphylaxis, and urticaria would present with wheals, pruritus, rapid onset, so minutes afterwards. So what you do is you just discontinue the drug and use topical steroids and antihistamines to help with the symptoms. And yeah, it's just a morbilliform drug eruption type 4 hypersensitivity reaction, 5 to 20 days afterwards. And it's T-cell mediated because it involves the CD4 T helper cells that release interferon gamma and then activates the macrophages and cytotoxic T cells to make the keratinocyte damage. And so you just got to stop the medication. But there we go. We got a lot of this activation here, and you can see how it's pretty painful and can cause the rash. So hopefully this was helpful. If it was, go ahead and like and subscribe.